Hello all. So today we're talking about chapter 8 and looking at minerals, primarily calcium today. So much research attention is currently being devoted to the role of mineral nutrition in health and disease, including both epidemiological and laboratory research. Laboratory studies using either animals or humans as subjects have explored the roles of both deficiencies and excesses of various minerals, including both essential and non-essential elements, on human health and disease processes. An increasing number of research studies have been conducted with athletes to evaluate the effect of mineral nutrition on physical performance, and the converse, the effect of exercise on mineral metabolism. Because some minerals function similarly to vitamins, a deficiency state could adversely affect performance. Moreover, exercise in itself may be a contributing factor to mineral deficiencies or impaired mineral metabolism in some types of athletes. Additionally, several mineral supplements have been marketed specifically for physically active individuals. This chapter is especially important to all females and young athletes because it addresses two of the very major dietary concerns: obtaining sufficient calcium and obtaining sufficient iron. These key minerals are of particular interest to females who participate in sports or are otherwise physically active. The female athlete triad, disordered eating, amenorrhea, and osteoporosis, is introduced in this chapter with a major focus on osteoporosis because of its relationship to calcium metabolism. An expanded discussion of eating disorders is presented in chapter 10. Female endurance athletes also need to obtain adequate dietary iron because of its important role in the oxygen energy system. The major purpose of this chapter is to analyze the available data relative to the effect of mineral nutrition on physical performance and health. The first section discusses some basic facts about the general role of those minerals that are essential to human nutrition. The second and third sections cover, respectively, the major minerals and the trace minerals. In these two sections, each of the minerals is discussed in terms of its dietary reference intake, or DRI, good dietary sources, metabolic functions in the body with particular reference to the physically active individual. An evaluation of the research pertaining to the efficiencies of the effects of deficiencies or supplementation on health or exercise performance and prudent recommendations. The last section summarizes dietary mineral nutrition guidelines for those who exercise for health or sport. The basic facts. So what are minerals and what is the importance to humans? A mineral is an inorganic element found in nature, and the term is usually reserved for those elements that are solid. Hence, a mineral is an element, but an element is not necessarily a mineral. For example, oxygen is an element, but it is not classified as a mineral. In nutrition, the term mineral is usually used to classify those dietary elements essential to life processes. Minerals are found in the soil and are eventually incorporated in growing plants. Most animals get their mineral nutrition from the plants they eat, whereas humans obtain their supply from both plant and animal food. Drinking water may also be a good source of several minerals. As minerals are excreted daily from the body in sweat, urine, or feces, they must be replaced. Minerals serve two of the three basic functions of nutrients in food: growth and development. Many minerals are used as the building blocks for body tissue, such as bones, teeth, muscles, and other organic structures. In particular, calcium and phosphorus are important to bone health. Iron is an important component of a hemoglobin, which is needed for optimal oxygen transport during aerobic endurance exercise. They are also used for metabolic regulation. A number of them are involved in the processes of metabolic regulation. Minerals are comparable to vitamins relative to energy production in humans. Although minerals may play a significant role in the generation of energy via their metabolic functions, they do not provide a source of calorie energy. Inadequate mineral nutrition has been associated with impairment of normal physiological functions, as well as with a variety of human diseases, including anemia, high blood pressure, obesity, diabetes, cancer, tooth decay, and osteoporosis. However, excessive intake of minerals may also contribute to significant health risks. Thus, proper dietary intake of essential minerals is necessary for optimal health and physical performance. Many are components of enzymes known as metalloenzymes. such as the cytochrome enzymes in the mitochondria that facilitate ATP production. Others, such as zinc and copper, are part of the natural antioxidant enzymes discussed in Chapter 7. Still others exist as ions or electrolytes, which are small particles carrying electrical charges. They are important components or activators of several enzymes and hormones. Speech and others reviewed the physiological roles of minerals important to athletes, noting that minerals are involved in muscle contraction, normal heart rhythm, nerve and pulse conduction, oxygen transport, oxidative phosphorylation, enzyme activation, immune functions, antioxidant activity, bone health, acid-base balance of the blood, and maintenance of body water supplies. Figure 8.1 provides a broad overview of mineral functions in the body. Minerals contribute to many functions in the body, as we just discussed. Mineral deficiencies, therefore, lead to a variety of health problems and may impair physical performance. So what minerals are essential to human nutrition? Of all the elements in the periodic table, only 25 are currently known to be or presumed to be essential in humans. 5 of these elements, hydrogen, oxygen, carbon, sulfur, and nitrogen, make up the carbohydrate, fat, and protein that we eat and the water we drink. They are the elements of the body water, protein, fat, and carbohydrate stores, which constitute slightly more than 96% of the body weight. The remaining 20 minerals compose less than 4% of the body weight, but are equally important. Table 8.1 lists those minerals for which the National Academy of Sciences has established a DRI or other recommendation. The DRIs include the recommended dietary allowance, or RDA, the adequate intake, and the tolerable upper intake level. The NAS has established the RDA or AI for most minerals discussed in this chapter and for sodium, chloride, and potassium, elements that are discussed in the next chapter. Sulfur is found in the diet mainly as a component of the sulfur-containing amino acids, methionine and cysteine, and body needs are satisfied by the RDA for these amino acids. In general, how do deficiencies or excesses of minerals influence health or physical performance? Similar to vitamin deficiencies, mineral deficiencies may occur in several stages. The first 3 stages, preliminary, biochemical deficiency, and physiological deficiency, may be termed subclinical malnutrition and may or may not have significant effects on health or physical performance. In the clinically manifest deficiency state, however, health and performance most likely will suffer. The interaction of exercise and mineral nutrition may pose some special health problems. As we shall see in later sections of this chapter, in regards to the preliminary stage of a deficiency, some athletes may reduce their mineral intake as they shift toward a low-calorie diet. Changes in food selection may also be important, for the bioavailability of many minerals is markedly influenced by the form in which they are consumed. In general, most minerals are poorly absorbed from the intestine. For example, the RDA for iron is 10 times the amount actually needed by the body because only about 10% of dietary iron from the average American diet is absorbed. Moreover, mineral absorption may be inhibited by certain compounds in foods, and supplementation with one mineral may impair the absorption of another. In athletes, factors that lower intake and absorption may be compounded because athletic activity may raise some mineral requirements. Additional minerals may be needed for the synthesis of new tissues associated with physical training or to replace losses often observed during and following intense exercise training via sweat, urine, and feces. Sports nutritionists are becoming concerned that the presence of these factors during the preliminary stage of a mineral deficiency could lead to the subsequent stages of subclinical malnutrition or even to a clinical deficiency. Based on dietary surveys and clinical studies with biochemical measures of mineral status, Pennington reported there is some concern for adequate calcium, iron, and zinc nutrition in some segments of the United States population. Most dietary surveys indicate that athletes, particularly males, are obtaining the RDA for all minerals. However, a number of studies have reported athletes with inadequate dietary intake and biochemical deficiencies of several minerals, predominantly athletes involved in weight control sports such as gymnastics, dance, figure skating, and wrestling. McClung and others recently noted that female athletes could be at risk for mineral insufficiency due to inadequate dietary intake. menstruation, and inflammatory responses to heavy physical activity. Experts disagree about the potential adverse effects of such dietary or biochemical deficiencies, but certain physiological and clinically manifest mineral deficiencies are known to have impaired physical performance. The human body possesses a very effective control system for some minerals. When a deficiency occurs, the body absorbs more of the mineral from the food in the intestine and excretes less via routes such as the urine. When an excess is consumed, the opposite is true. Less is absorbed and more is excreted. However, the body has a limited ability to excrete certain minerals, so excessive consumption may override these natural control systems and cause a number of health problems, even in relatively small dosages. Additionally, a few minerals not important to human nutrition, such as lead, mercury, cadmium, and arsenic, as well as some industrial forms of silicon and chromium, may be extremely toxic to the human body. For example, as discussed in Chapter 5, mercury in polluted waterways may accumulate in fish, which, if eaten, may damage the nervous system of unborn or young children. And here you see the 7 macro minerals, or major minerals, are calcium, phosphorus, magnesium, potassium, sodium, chloride, and sulfur. And then the trace minerals of iron, copper, zinc, chromium, selenium, boron, vanadium, manganese, fluoride, and iodine. The RDA or AI is greater than 100 milligrams per day of the body, or the body contains more than 5 grams. In general, the human body maintains a proper balance of these minerals through precise hormonal control mechanisms, but deficiencies or excesses may occur and disturb normal physiological functions, thus impairing health or physical performance. Sulfur, an integral component of several amino acids and vitamins, is not discussed here because its functions are associated with those nutrients. Because potassium, sodium, and chloride are the major electrolytes in sweat and in some sports drinks, they are covered in the following chapter dealing with water and temperature regulation. Minerals are classified as macrominerals if the RDA or AI is greater than 100 milligrams per day, or the body contains more than 5 grams. In general, the human body maintains a proper balance of these minerals through precise hormonal control mechanisms, but deficiencies or excesses may occur and disturb normal physiological functions, thus impairing health or physical performance. These are some foods that are high in calcium as well as phosphorus and magnesium. You also notice that it does demonstrate deficiency symptoms and symptoms of excessive consumption as well. Calcium is a silver-white metallic element, is the most abundant mineral in the body, representing almost 2% of the body weight. The DRI, the AI for calcium, is intended to replace daily losses in the urine, feces, and sweat and provide optimal amounts for health, particularly for bone health and the prevention of osteoporosis. The daily recommendations are given for several selected age groups. Children 1 to 3, they need about 700 milligrams. Youth 4 to 8 years old, 1,000 milligrams. Youth and adolescents 9 to 18 years of age, 1,300 milligrams. And then adults 19 to 50, 1,000 milligrams. Adults 51 to 70, men need about 1,000 milligrams versus women that need about 1,200 milligrams. And adults over the age of 71 need about 1,200 milligrams. Now, pregnant and breastfeeding women should get the amount recommended for their age group. The daily value is 1,000 milligrams. The UL for adults 19 to 50 is 2,500 milligrams. Calcium content is highest in dairy products. 1 8-ounce glass of skim milk, which contains about 300 milligrams of calcium, supplies about 1/3 of the RDA for adults and men over 50, and about 1/4 of the RDA for adults and women over 50. It is used as the basis of comparison for other foods. Other equivalent dairy products or foods are 1/2 ounce of cheese, 1 cup of yogurt, and 1 3/4 cups of ice cream. Dairy products supply more than 70% of daily calcium intake for adults. Other good sources are fish with small bones, such as sardines and canned salmon, dark green leafy vegetables, particularly broccoli, kale, and turnip greens, calcium set tofu, legumes, and nuts. Incorporation of milk or cheese into foods such as soups, pasta dishes, and pizza is an excellent way to obtain dietary calcium. For individuals with lactose intolerance, the use of yogurt, lactase enzymes, or smaller portions of milk may be helpful. Calcium is also used as a preservative in some foods such as breads, which may provide small amounts. Additionally, some food products such as fruit juice and cereals are now being fortified with calcium. One serving of orange juice may contain 300 to 350 milligrams, while one brand of cereal contains 100% of the calcium DV. Calcium is one of the key nutrients listed on food labels, and although the food label does not indicate the milligrams of calcium per serving, you can calculate the amount fairly easy. The daily value for calcium is 1,000 milligrams, and the label will provide you with the percentage of the calcium DV contained in one serving. All you need to do is multiply the percentage as a decimal times 1,000 milligrams. For example, if a glass of calcium fortified orange juice provides you with 30% of the DV, then it contains 300 milligrams of calcium. Both the United States and Canada have approved food label health claims for calcium if one serving contains 20% of the daily value, or 200 milligrams. Tichdal and Dobbs developed a system to assess the quality of food sources for calcium. The system is based on two criteria: the amount of calcium per serving, including nutrient density, and its absorbability. Substances found in some foods may enhance or impair calcium absorption in the gastrointestinal tract. Calcium in milk appears to be absorbed more readily because vitamin D and lactose in milk facilitate absorption. Dietary phosphorus may also decrease calcium absorption, but decreases its excretion by the kidneys as well. So its effect on calcium balance is somewhat neutral. Excess sodium intake increases calcium excretion. Excess dietary protein, as mentioned in Chapter 6, may lead to calcium excretion. An estimate cited by the National Dairy Council being 1 milligram of calcium lost for every gram of protein consumed. However, as also noted, adequate protein intake is needed to optimize calcium bone metabolism. High intakes of coffee and alcohol may increase calcium loss from the body. Although studies have shown that up to 5 cups of coffee and moderate alcohol consumption appear to have little effect on calcium balance. Overall, however, calcium balance in the body is attributed mostly to adequate calcium intake. Although certain food constituents may impair the absorption of calcium, the effect is not as great as once believed. In general, the amounts of protein, phosphorus, fiber, phytates, and oxalates found in the average North American diet do not appear to pose a problem for calcium absorption. For example, research has revealed that vegetarian diets provide adequate calcium nutrition as measured by body stores. Nevertheless, non-lacto-vegetarian females, as well as females engaged in sports-associated dieting for weight control, should be sure to include calcium-rich foods in their diet. As we shall see, the major factor underlying calcium deficiency is inadequate calcium intake. And although some of these dietary factors may adversely influence calcium balance if taken to excess, their effect is lessened if calcium intake is adequate. Substances found in some foods may enhance or impair calcium absorption in the gastrointestinal tract. Calcium in milk appears to be absorbed more readily because vitamin D and lactose in milk facilitate absorption. Dietary phosphorus may also decrease calcium absorption, but decreases its excretion by the kidney as well, so its effect on calcium balance is somewhat neutral. Excess sodium intake increases calcium excretion, and therefore excess dietary protein may lead to calcium excretion. However, as noted, adequate protein intake is needed to optimize calcium bone metabolism. Overall, however, calcium balance in the body is attributed mostly to adequate calcium intake. Although certain food constituents may impair the absorption, the effect is not as great as once believed. Nevertheless, non-lacto-vegetarian females, as well as females engaged in sports-associated dieting for weight control, should be sure to include calcium-rich foods in their diet. The vast majority of body calcium, 98%, is found in the skeleton, where it gives strength by the formation of salts such as calcium phosphate. 1% is used for tooth formation. The remainder, which exists in an ionic state or in combination with certain proteins, exerts considerable influence over human metabolism. Intracellular calcium ions are involved in all types of muscle contraction, including that of the heart, skeletal muscle, and smooth muscle found in blood vessels such as the arteries. Calcium activates a number of enzymes. In this capacity, it plays a central role in both the synthesis and breakdown of muscle glycogen and liver glycogen. Calcium also helps regulate nerve impulse transmission, blood clotting, and secretion of hormones. It should be noted that the skeletal content of calcium is not inert. The physiological functions of calcium, such as nerve cell transmission, take precedence over formation of bone tissue. If the diet is low in calcium for a short time, the body can mobilize some of the skeleton through the action of hormones such as parathormone and calcitrol, a hormonal form of vitamin D, to maintain an adequate amount in ionic form. Weaver and Heaney note that given the large skeletal reserves, impaired metabolic processes associated with calcium deficiency are almost non-existent. Here in figure 2, you'll see the calcium balance in an adult who requires 1,000 milligrams daily. On an intake of 1,000 milligrams, only 30% or 300 milligrams are absorbed into the body, the remaining 700 milligrams being excreted in the feces. To maintain calcium balance, 300 milligrams are excreted, including an additional 150 milligrams in the feces, 130 milligrams through the kidneys to the urine, and 20 milligrams in sweat. The major health problems associated with impaired calcium metabolism involve diseases of the bones. A number of factors are involved in the formation of mineralization of bone tissue, including mechanical stresses such as exercise, hormones such as parathormone, calcitrol, vitamin D, and estrogen, and dietary calcium. An imbalance in any one of these factors could lead to bone demineralization, resulting in the development of rickets in children, osteoporosis in adults. Rickets is most often associated with vitamin D deficiency and is discussed in Chapter 7. Osteoporosis, a thinning and weakening of the bones related to loss of calcium stores, is a debilitating disease that affects more than 200 million people worldwide. Aseth and others described osteoporosis as a multifactorial disease with potential contributions from genetic, endocrine, exercise, and nutritional factors, with the last including calcium, vitamin D, fluoride, magnesium, and other trace elements. Osteoporosis is age and gender related, being prevalent in white postmenopausal women. However, a National Institutes of Health panel noted that osteoporosis occurs in all populations and at all ages and has significant physical, psychosocial, and financial consequences. The National Institutes of Health also indicated that females older than 50 years do not get the recommended amount of calcium, but has also noted the other age groups are at risk, including boys 9 to 13 years, girls 9 to 18 years of age, and men over the age of 70. The NIH indicated that other than these specific age groups, some other groups of people may be at risk of calcium inadequacy. Individuals with lactose intolerance or cow's milk allergies, such conditions may eliminate milk from the diet, a major source of dietary calcium. Women with anorexia nervosa and eating disorders which may interfere with calcium metabolizer are discussed in Chapter 10. Some vegetarians, those who consume no dairy products, particularly vegans, are at risk. Female athletes and weight control sports. Such athletes may be predisposed to the female athlete triad, discussed later in this section, which disrupts calcium metabolism. Additionally, studies indicate that strenuous exercise may increase calcium losses in the sweat. Inadequate dietary intake of calcium is the major cause of calcium deficiency. The National Health and Nutrition Examination Survey is designed to analyze the nutrient content of the diets of Americans. In a recent NHANES report, What We Eat in America, Hoy and Goldman indicated that 42% of Americans, mainly females, did not meet the recommendations for daily intake of calcium. In particular, older females obtained substantially less calcium than recommended. However, the report provided some good news. indicating that dietary calcium intake has shown an increasing trend since the mid-1990s, with approximately 85 to 190 milligrams more calcium consumed daily across age groups. Figure 8.3 demonstrates the three principal sites of osteoporosis fractures: the spinal vertebra, the wrist, and the hip. A positive family history or heredity and low levels of estrogen are the two primary risk factors in women. Caucasian and Asian women are at a higher risk for osteoporosis than women of African ancestry. Following menopause, estrogen production is diminished. Estrogen is a hormone essential for optimal calcium balance in women. Bone receptors for estrogen have been identified, indicating an active role in bone metabolism. In general, reduced levels of estrogen lead to negative calcium balance and a rapid onset of bone demineralization. This softening of the bones predisposes to fractures, particularly in the spine, the end of the radius in the forearm, and the neck of the femur at the hip joint. The latter two fractures may be completely debilitating to the older individual. The spinal fracture is more common because the vertebrae are composed of trabecular bone, a spongy type of bone more susceptible to calcium loss than the more dense, compact bone. Here in figure 8.4, in osteoporosis, impaired calcium metabolism may decrease the external compact bone thickness and the strength of the internal trabecular bone lattice network. A recent report analyzed osteoporosis-related fractures in the United States from 2005 and projected to 2025, indicating more than 2 million fractures in 2005 with a healthcare cost of $17 billion. Fractures including vertebral, wrist, hip, pelvic, and other bones. Annual fractures are projected to increase by almost 50% in 2025, although most of the fractures were in women, almost 30% occurred in men. Osteoporosis is known as the silent killer. The disease itself causes no pain, but following a serious bone fracture, nearly a third or more of women and men died due to accompanying illnesses within a year. Health professionals recommend that women age 65 and over and others with risk factors for osteoporosis routinely have measurements of bone mineral density. Although heredity and estrogen status are strong risk factors for osteoporosis, some lifestyle factors may impair optimal bone metabolism. Both physical inactivity and inadequate dietary intake of calcium are risk factors for osteoporosis, and so are cigarette smoking, stress, and various medications. All these factors may influence peak bone mass, the highest bone mass in young adulthood. Modifying your lifestyle to increase your peak bone mass is like putting money in the bank for later in life. However, Modleski and Lewis note that although the idea that the growing years are an opportune time to optimize bone mass and strength certainly has merit, the importance of these gains depend largely on their permanence. Thus, you need to continue to practice good dietary and exercise habits to maintain optimal bone health. Relative physical performance. The effect of calcium deficiency depends on whether calcium levels are low in the blood or in the bones. Serum calcium levels are usually regulated by several hormones in the average individual. The body can adapt to low dietary intake by increasing the rate of absorption from the intestines and decreasing the rate of excretion by the kidneys. Because the skeleton is a large reservoir of body calcium, low serum levels are rare. When they do occur, it usually is because of hormonal imbalances rather than dietary deficiencies. Fortunately, serious deficiencies of serum calcium are rare in athletes because hormones may extract calcium from the bone as needed. Nevertheless, as shall be noted, bone health is one of the major concerns in the female athlete triad. Considerable research has focused on the role of calcium supplementation, often in concert with vitamin D supplementation, on bone health. Herney notes that each nutrient is necessary for the full expression of the effect of the other, and while their actions are independent, their effects on skeletal health are complementary. In addition, exercise may play a role in enhancing bone health. As noted above, bone health is an important consideration, particularly for the aged. Although genetic factors are involved in optimal bone health, so are lifestyle factors, particularly diet and exercise. The following discussion focuses on the role of supplements, particularly calcium, along with vitamin D, exercise and drug therapy, as well as a brief discussion of osteoporosis in sports. However, based on results from the Women's Health Initiative study, which included a calcium and vitamin D trial, colleagues concluded that overall, the common practice of taking calcium and vitamin D supplementation with possible benefits for the hip and positive evidence for increased bone mineral density and with few risks is reasonable. For those who desire to take a calcium supplement, it may be wise to take a tablet with about 200 milligrams with snacks and small meals 3 times a day, rather than one tablet with 600 milligrams, as it appears that more calcium is absorbed when the intake is spread throughout the day. Moreover, when the supplement is combined with meals, gastric acidity and slower transit time in the gut promote calcium absorption. A daily total supplement of 600 milligrams of calcium combined with the dietary intake of 500 to 600 milligrams should provide adequate calcium nutrition for most individuals. Multivitamin and mineral tablets normally contain about 200 milligrams of calcium, or 20% of the AI. However, 3 tablets are needed to provide 600 milligrams of calcium and may not be the best means to obtain calcium because the 3 tablets may provide excess amounts of other nutrients such as vitamin A. Exercise places a mechanical stress on the bone, stimulating mechanical receptors that facilitate the deposition of calcium salts and an increase in bone mass and density. In a review of exercise regimens to increase bone strength, Turner and Roebling indicated that mechanical loading through exercise will add bone, and a small amount of added new bone results in dramatic increases in bone strength. Because the location of the new bone through exercise is where mechanical stresses in the bone will cause fracture. However, they note that not all exercises are equally effective. Dynamic exercise as compared to static exercise creates a unique stress on the bone to stimulate bone strength gains. Dynamic high-impact stresses such as running and jumping may stimulate bone growth more than low-impact exercise. Age is an important consideration in optimizing bone mass with exercise, and youth is the age of opportunity. Although adult bone health is dependent on maximal attainment of peak bone mass in youth and the prevention of bone loss during young adulthood, whether or not exercise prevents bone loss after menopause appears to be debatable. Calcium supplements come in a variety of forms, such as calcium carbonate, calcium citrate, calcium lactate, and calcium gluconate, and are found in certain acids such as Tums. Weaver and Heaney note that calcium from most supplements is absorbed as well as from milk, but a few calcium salts, including calcium citrate, malate, and calcium ascorbate, have superior absorbability. Be sure to check the label for the calcium content per tablet, which may range from 50 to 600 milligrams depending on the brand. Be aware that some forms of calcium supplements may be contaminated with lead. Adequate calcium intake may be the answer to these varying viewpoints, as it may be needed to complement the effects of exercise. Zernicke and others indicate that exercise produces increases in bone mineral density only when calcium intake exceeds 1,000 milligrams daily. And it generally is accepted that chronic exercise and dietary calcium can improve bone mass to a greater extent than calcium intake alone. However, others suggest that exercise provides minimal, if any, benefits. The American College of Sports Medicine, or ACSM, in a position statement on physical activity and bone health indicated that although physical activity for optimal bone health is important across the age spectrum, currently there is no strong evidence that even vigorous physical activity attenuates the menopause-related loss of bone mineral in women. These findings were recently confirmed in a review by Fonseca and others, noting that most exercise intervention studies reveal either no effect or only minor benefits of exercise programs in improving bone mineral density in osteoporotic patients. However, they note that exercise interventions in patients with osteoporosis may be beneficial by improving other determinants of bone strength, such as collagen properties and osteocyte density. The optimal program for older women would include moderate to high impact activities that improve strength, flexibility, and coordination that may increase postural stability and decrease the incidence of osteoporotic fractures by lessening the likelihood of falling. Exercise will stimulate bone development, but optimal calcium intake approximating 1,000 milligrams or more daily appears to be equally important, although the ACSM does recommend exercise throughout the lifespan for bone health. It also indicates the pharmacological therapy for the prevention of osteoporosis may be indicated even for those postmenopausal women who are habitually physically active. Hormone replacement or non-hormonal drug therapy. In the past, hormone replacement therapy, or HRT, involving estrogen, possibly combined with progesterone, was commonly used for prevention and treatment of osteoporosis, and as noted by the Consumers Union, a host of other health benefits. However, in a report from the NIH Women's Health Initiative, the biggest hormone study ever done, women on estrogen progestin therapy were at increased risk for breast cancer, heart attacks, and strokes as compared to women not taking these hormones. Following this report, Byrne highlighted the updated FDA recommendations for postmenopausal women and the use of estrogen-containing drugs. The recommendations vary depending on the health conditions, and if a woman and her health care provider decide that estrogen-containing products are appropriate, they should be used at the lowest doses for the shortest duration to reach treatment goals. In a recent review, Cawley noted that use of hormone therapy solely for the prevention of osteoporosis is not recommended. Various non-estrogen drugs are available to help treat or prevent osteoporosis. In 2006, the Consumers Union indicated that biphosphonates remain the optimal treatment for osteoporosis, and a recent review by ASETH and others note biphosphates are still the drugs of choice. Biphosphonates represent a class of drugs that inhibit the osteoclast, thereby decreasing resorption of bone, but they do not inhibit bone mineralization. Thus, they prevent bone loss and possibly increase bone mineral density. Brand names for biphosphonates include Fosamax, Boniva, and Reclast. Some forms, such as Boniva, may need to be taken orally only once a month. The FDA-approved Reclast, which requires only a yearly 15-minute infusion, which may help women who do not adhere to other regimens where pills must be taken on a regular basis. However, in 2008, the FDA reported various adverse side effects associated with biphosphonate use. The hormone testosterone has also been used, particularly with males, as have other non-hormonal drugs for the prevention and treatment of osteoporosis, but they also may have adverse side effects. Individuals who wish to seek medical treatment for osteoporosis should consult with a medical specialist who treats the disease. Your family doctor may treat you or refer you to a doctor with expertise in osteoporosis. I'm lost. Although osteoporosis occurs primarily in older individuals, investigators are expressing serious concern regarding disturbed calcium metabolism in young female athletes, particularly endurance athletes, and those involved in weight control sports. The female athlete triad, disordered eating, amenorrhea, osteoporosis, has been reported in numerous studies. Although the exact cause has not been identified, the underlying behavior appears to be disordered eating. Females who attempt to lose body weight in order to improve their appearance or competitive ability in sports may modify their diets, decreasing energy and protein intake. They may also exercise excessively to burn calories. Restrictive diets and excessive exercise regimens may affect hormone status in various ways, including disturbed functioning of the hypothalamus and pituitary glands, two glands that significantly influence overall hormone status in the body, including female reproductive hormones, and decreased levels of body fat, which may lead to a reduced production of estrone, a form of estrogen. Secondary amenorrhea, or sensation of menses for prolonged periods, is a classic sign of disturbed hormonal status associated with disordered eating in postpubertal females, as seen in patients with anorexia nervosa. When observed in athletic females, secondary amenorrhea is often referred to as athletic amenorrhea, and it may involve oligomenorrhea or intermittent periods of amenorrhea. In young female athletes, athletic amenorrhea is often associated with osteoporosis. Most recently, the International Olympic Committee updated its consensus statement on the female athlete triad and now refers to it as relative energy deficiency in sport, or REDS. Mountjoy and others note that REDS is more comprehensive than the female athlete triad, but some debate this classification. We talk about this a little bit more in Chapter 10. The medical treatment suggested for this condition depends on the point of view of the individual endocrinologist and may include individualized hormone drug therapy. An appropriate physician, such as a sports-oriented gynecologist, should be consulted. Males are at less risk for developing osteoporosis than females. However, reviews by Seaman and by Bennell and others noted that low calcium intake, weight loss, low body fat, and excess alcohol intake, along with other risk factors, may adversely affect bone density in males. Depressed hormone levels such as testosterone and insulin-like growth factor, or IGF, may also be associated with decreased bone density. As discussed in Chapter 10, the American College of Sports Medicine indicates that medical attention is mandatory for athletes with disordered eating or amenorrhea, noting that treatment of the triad often requires intervention via a team approach, including a physician, a nutritionist, a psychologist, and the support of family, friends, teammates, and coaches. Some scientists have expressed concern about the potential adverse effects of excess calcium intake, particularly from supplements, on cardiovascular health. According to Rodolin and others, laboratory studies suggest that calcium may be involved in cardiovascular disease development through multiple pathways. One concern is calcification of blood vessels, which could impair blood flow in the coronary arteries. The current state of affairs relative to the role of calcium supplementation in the development of cardiovascular disease is probably best expressed by Rodolin and others. In their review, they note the results of research trials suggest calcium supplementation has no effect on cardiovascular disease development, but current research findings also do not allow a definitive conclusion to be drawn. They conclude that only large-scale randomized trials designed to investigate the effects of calcium supplementation on cardiovascular disease events as the primary endpoint, as well as short-term trials investigating the effect on coronary artery disease biomarkers, can provide a definitive answer. The role dietary calcium plays in cancer development appears to be complex. Abbott and others cite research suggesting that dietary calcium probably decreases the risk of colorectal cancer, but diets high in calcium probably increase the risk of prostate cancer. On the beneficial side, calcium may bind with carcinogenic compounds in the intestines, which may inhibit their effects on cells in the colon and rectum. The National Cancer Institute noted that the most authoritative review of existing evidence relating nutrition to cancer risk, a 2007 report by the World Cancer Research Foundation and American Institute of Cancer Research, concluded that calcium possibly has a protective effect against colorectal cancer. In a recent meta-analysis, Hine and Boring and others observed inverse associations for colorectal cancer risk and calcium supplements, suggesting a beneficial role for calcium supplements in the prevention of colorectal cancer. On the negative side, the high serum calcium levels may be more at risk for prostate cancer with men. And theory is that calcium may interact with parathyroid hormone to promote prostate cancer. The National Cancer Institute indicates some studies suggest that a high calcium intake may increase the risk of prostate cancer, but results of more recent systematic reviews and meta-analysis are somewhat conflicting. Calcium supplementation has been theorized to promote weight loss. Zimmel indicated that low calcium diets cause an increase in calcitrol, the vitamin D hormone, which can stimulate adipose cell calcium influx, promoting fat accumulation. He also notes the converse: the higher calcium diets inhibit the formation of body fat. Zimmel and others in several studies have shown that supplementing a reduced calorie diet with calcium in particular calcium-rich dairy products led to greater weight loss compared to placebo groups. However, most other studies comparable to the design of those of Zimmel reported no beneficial effects of high calcium diets or supplements on weight loss. The results of 2 recent reviews are somewhat contradictory. De Oliveira, Freitas, and others indicates that results of most studies suggest that calcium ingestion may improve body composition. Conversely, Soares and others analyzed the effects of 15 randomized controlled trials on calcium with or without vitamin D and indicated the evidence does not consistently support the contention that calcium accelerates weight or fat loss and obesity. Kidney stones can form in the urine and can cause pain in the urinary tract if they are too large to pass. There are several forms of kidney stones, the most common being calcium oxalate formed from calcium and oxalate in the urine. Possible causes of kidney stones include inadequate fluid intake, too much protein intake, too much salt or too much sugar, especially fructose. However, Weaver and Herney note that kidney stones are not caused by dietary calcium. They note that although kidney stones contain calcium oxalate, it is the oxalate that may be the problem. They also note that actually increasing calcium intake to about 1,200 milligrams daily may reduce the risk of kidney stones, as the calcium can bind oxalate in the intestines and lead to excretion, thus decreasing the amount of oxalate in the body. Research regarding the effect of calcium supplementation on physical performance is almost non-existent. Giving its theoretical role in fat metabolism and weight loss programs, White and others investigated the acute effect of calcium on fat metabolism and exercise performance in trained female runners. The subjects consumed either high calcium or low calcium drink 60 minutes prior to a 90-minute run at 50% VO2 max. At 70% VO2 max, which was followed by a 10-kilometer treadmill time trial. The high calcium drink did not affect carbohydrate or fat metabolism during the 90-minute run or 10-kilometer run time. In a similar study, Gonzalez and others investigated the effect of 2 weeks of calcium supplementation, 1400 milligrams daily, on carbohydrate and lipid metabolism during a cycling-based exercise test. However, the supplement did not affect either carbohydrate or fat utilization rates during the exercise tasks. Calcium may be combined with other salts such as lactate to form calcium lactate, which could be used to buffer lactic acid during exercise. Pianelli and others recently studied the effect of calcium lactate on intense anaerobic exercise, and although there were increase in bicarbonate and the alkalinity of the blood, performance on intense Wingate cycling tests were not improved. Low serum calcium levels may impair neuromuscular functions, but such conditions are rare because the body will draw from calcium reserves in the skeleton to restore serum levels. In a review, Kunstler concluded that increased physical activity does not necessarily demand an increased intake of dietary calcium. Thus, acute or chronic calcium supplementation is not recommended as a means to enhance sports performance. However, calcium supplementation may be useful to help maintain bone mass in some female and male athletes, particularly those who do not consume adequate calcium from foods. Adequate daily calcium intake and weight-bearing exercise are very important during the developmental years of childhood and adolescence to maximize peak bone mass, and such practices should be continued throughout adult life. Weaver and an expert in calcium metabolism recently indicated that the current RDA for calcium appear to be a good target, and potential risk for chronic diseases may occur if intakes fall too short or greatly exceed these recommendations. Calcium supplementation may be recommended to attain the RDA in individuals who do not attain a sufficient amount through their normal diet. To help prevent osteoporosis, postmenopausal women and elderly men should obtain about 1,200 milligrams of calcium per day, along with adequate vitamin D, about 200 to 600 IU. Both weight-bearing, aerobic, and resistance strength training exercises are recommended. Postmenopausal women should consult with their physicians relative to hormonal replacement or drug therapy. Older men should obtain adequate calcium exercise and consult their physicians for appropriate drug therapy if warranted. For younger premenopausal women, the non-pharmacological approach is recommended. The key with younger women and men as well is prevention. They need to develop peak bone mass, the optimal amount within genetic limitations prior to age 25 and 30, and attempt to keep the bone mass high in the advancing years. Health professionals note that because evidence suggests that osteoporosis is easier to prevent than to treat, initiating sound health behaviors early in life and continuing them throughout life is the best approach. To make a success of it, you've got to start young. Thus, it would appear prudent for young women to develop a lifetime exercise program and obtain AI of 1,000 to 1,300 milligrams for calcium in the diet. The earlier the better, for research has suggested a greater increase in bone mass when calcium supplements are given to a prepubertal children for adequate calcium intake is critical for adolescents as well. Weight-bearing exercises such as walking or jogging promote bone mineralization by stressing the hips and spine, while resistance training and modified push-ups are also excellent for the spine and for the radial bone at the wrist joint. Thank you all for joining me today.